Yeah. Start. We can start.
Yeah. So I'll be showing some cases of herpes simplex. So I'm not going into the details of herpes simplex. I'll just go through the principles of management. So as we know, it's characterized by latency in the trigeminal ganglion, and it can be triggered by three, either the ganglion trigger, the skin trigger, or the combined trigger. So primary is something which we usually do not see. Sometimes we can come across a patient with herpetic vesicles on the lids, primary herpes simplex, or sometimes SPKs also can be there in primary infections. Mostly what we come across in our clinics is the recurrent infection. Some may give a history of a previous infection. Some we might not get any history. So we have the epithelial variety, the stromal variety, the endothelitis, and iridocyclitis. So uveitis I am not going to cover. So we'll be covering the corneal manifestations of HSV. So epithelial is mostly due to active viral replication. So we must remember that wherever there is active viral replication or invasion, there we need to give topical antivirals. So as you can see on the left side, these are SPKs. On the right side, there are very distinguished dendrites. So SPKs will be fine and feathery. If I take a class on SPKs, it will be a whole big class. So in HSV, characteristically, they are very fine and feathery. And they usually, either they resolve or they break down into dendrite. So they are very fine and feathery, and they'll be mostly in the central part of the cornea. You very rarely see HSV SPKs in the periphery. And this is a dendrite, classical dendrite, where you see a fine branching pattern. So here on the left side, you have a breakdown of the epithelium. So this is like a geographic pattern. And on the right side, I could not get a proper picture, but what I wanted to show you is the marginal keratitis. So HSV marginal keratitis also we must be aware of. So here what I wanted to show is how do you differentiate a dendrite or a HSV infection from any other kind of infection like a pseudodendrite. So when we do a vital staining of HSV keratitis, the bed will take stain. Whereas the dead cells at the periphery or at the ends of the knobs, they will not take stain. So this is like a late staining pattern. However, you can still see that the base of the ulcer has taken a stain, and these cells here, they have not taken a stain. You can also do a counter staining. So this is just to know the difference between how a vital stain will take up and how a supravital stain will take up. So as we all know, rose bengal is a supravital dye, whereas the fluorescein is a vital stain. So fluorescein will stain the bed of the ulcers, whereas the dead cells will take up rose bengal. So here if you can see a counter staining with rose bengal, this is just to highlight the pattern. Wherever you're in doubt, you can always do this. So I don't.
Can I interrupt you for a minute?
Yeah.
I have no idea how to use rose bengal. I've never seen it also.
I don't use it. I don't use it. So you get them in strips. You get them in strips, but it is highly irritant. So you do not use rose bengal. And if at all you use rose bengal, please put a drop of paraffin before you do any staining.
Is it mandatory to use rose bengal in any of these situations?
I don't use. I don't use. So this was just to show the counter staining. I don't use.
Okay.
Use them even in dry eyes also, because as such the surface is very irritable. I don't stain them with rose bengal. Like I don't use rose bengal at all. Yeah. So in epithelial keratitis, am I audible?
Yes.
Yeah. So in epithelial keratitis, since there is active viral replication. So we have to use topical antivirals, and approximately 2 to 3 weeks. You can debride them. I don't debride. And if you debride, use a cotton tip applicator so that you don't damage the basement membrane. And wherever you have any coexistent conjunctivitis or any neurotrophic component, there we should not debride at all. And we can use adjuvants like lubricating drops and cycloplegics.
Ma'am, I have a question here. I have stopped using ACV ointment completely, acyclovir. I'm just using ganciclovir. Is it fine? Because I find it. Sorry.
Yes, it's less toxic. I use ganciclovir.
Okay. Thank you.
Ganciclovir.
Ma'am?
Excuse me, ma'am. Yeah.
Yeah, Simran, you go first.
Yeah, just wanted to know the dose of ganciclovir ointment. Is it TDS or 5 times a day, ma'am?
Times. Wherever you have active viral replication, use it 5 times. So I used to use it 5 times daily for 2 weeks, but now I've started tapering to 5 times for 1 week, 4 times for 1 week, and 3 times for 1 week, just
All
not to
right.
get the epithelial toxicity.
Right. Right, ma'am. Thank you.
And I stop at 3 weeks. I don't go beyond 3 weeks with topical unless there is some other indication.
Right, ma'am.
And I 5, 4, 3 week.
I didn't get you, ma'am. Is ganciclovir more toxic or the acivir is more toxic?
Acivir.
Okay, thank you.
Ma'am, I would like to ask how common is pediatric blepharoconjunctivitis due to HSV? Do you commonly see it? And if so, how is the treatment different?
Blepharoconjunctivitis, if you do see, unless there is any other indication of evidence of systemic immunosuppression, I do not go for oral acyclovir. I just go for topical application, topical ganciclovir application and lubricating drops. And then I follow them after 7 to 8 days, after 1 week, because usually the corneal manifestations will develop slightly later than the blepharoconjunctivitis, if at all. So I just give them, apply the ointment over the lids. And if there is some conjunctivitis element, then I give lubricating drops. And then I call them up for review after 1 week. After 1 week, if I see any corneal affection, then I start on local application also. Otherwise, I don't on systemic cyclovir.
Yes. Thank
Ma'am,
you.
you don't recommend debridement because I do it regularly.
Debridement actually, I don't do in my practice because first of all, I didn't find any difference between debridement and no debridement. And secondly, I get so many patients that if I were to debride them, then I would sit the whole day. So I don't debride. I don't debride except in fungal ulcers. I don't debride any other ulcers.
Okay.
So management of neurotrophic keratitis, firstly, it is important to identify the neurotrophic keratitis because you have to differentiate it from the primary HSV keratitis, and the management will be completely different. So sometimes along the course of treatment, if we see that in spite of full medication, the lesions do not come down or tend to increase, then keep the suspicion of neurotrophic keratitis very high. And they will come in 3 stages. First is punctate keratopathy, which you will very often confuse with the original SP case. And then they will break down and there will be an epithelial defect and ulceration. And gradually this ulceration will progress in spite of maximal antiviral treatment. So it is very important to identify whether it is a neurotrophic keratitis or whether it is a primary HSV keratitis. So if a patient has been compliant and you have been using your standard dosage of antivirals, and the patient does not respond over a period of time or has a waxing and waning kind of, this is from my experience, waxing and waning kind of presentation, like it was coming down and again it increased, or else the lesions appear to increase, then keep that element of doubt. So first it will be a punctate lesion. If you can identify it, then it is better to stop all the topical antivirals, use the lubricants. Then stage 2 epithelial defect, again stop all the epitheliotoxic lubricants. Nowadays, very rarely we have these toxic preservatives. We can add a BCL, tarsorafine AMG. I have never needed to. And if the ulcer is progressing, just give a prophylactic antibiotic like a chloramphenicol will do. Then you can give topical and systemic anticollagenolitics and manage the complications. So any
Excuse me,
doubt?
ma'am. Ma'am, what do we use in topical anticollagenolitics?
Topical, usually vitamin A drops and vitamin C, I have never used. I always use doxycycline and systemic doxycycline, systemic vitamin C.
Right,
Ma'am,
ma'am.
actually, why are we exactly talking about neurotrophic keratitis here? Matlab, in case in the viral perspective, is it more commonly confused with it, or like?
Yeah, because sometimes we see patients who have been on treatment elsewhere over a long period of time, and then it's very difficult to sometimes identify whether it's a neurotrophic keratitis or whether it is a HSV keratitis, because the sensation will be diminished in both.
Okay. Yeah, matlab, so because of the loss of sensation. Yeah, okay, fine.
And then the management will become completely different. Here you up the antivirals and there you stop the antivirals. So it's very important to identify that kind of presentation. We get them, we do get them, especially patients who have been on a long-term treatment. And I did have one patient who primarily worsened with topical ganciclovir. Like after 7 days, then I stopped her ganciclovir. Then again it increased. Then again I started. Then again somehow.
What was the sign of worsening with
Because
ganciclovir?
worsening of a vision. She came back to me within 1 week because she felt a worsening in her vision. So I saw the number of lesions had increased centrally. And then I told her that it's a normal viral course and I sent her back. Then she came back within another 3-4 days saying that no, ma'am, it has worsened a lot. Then I thought, why has he worsened so much? Then I lowered her topical antiviral. In spite of lowering, also it did come down. So the next visit, I stopped it altogether and I put her on systemic acyclovir, short course, 10 days, and just topical lubricant. She got better. She got completely better.
Sorry, ma'am, last question in this. So you prefer oral acyclovir or Velcivir? Matlab, basically, I have now switched over to Velcivir completely. One for the ease of dosing, then
Ease of dosing is there, but since I have been using acyclovir since a long time, I use acyclovir very rarely. Systemic acyclovir I use very rarely, and in my usage is very defined. So I don't use them too much. Like if I have 100 patients of HSV, I might be using it in 1 or 2. And I have my own criteria. And since I'm already using acyclovir in such a small percentage of my patients, I don't find the need to change to valcyclovir. You could change. In fact, in herpes zoster infection, you could change. Herpes simplex, I find the use very minimal. So I don't find the necessity to change. You could ask me where I use. I'll come to
please.
that. I'll come to
So,
that.
Stromal.
Yeah.
Oral in predominantly in stromal keratitis.
yes.
I do not give oral. Like I said, this case I gave oral. I gave oral acyclovir in recurrent cases, resistant cases, recurrent cases. That too, my criteria is very fixed. The patient must have been compliant. I must be having a fair idea of the patient's frequency of recurrences, how they have happened between his last visit and the present visit. And the patient must be willing to take it for a long term, because I just give it 1 month or 2 months, it doesn't make sense. So I usually give them long term, at least 4 to 6 months start of, I tell them. So if they're willing to go ahead with that, only then I give. Otherwise, it doesn't make sense giving them for 1 month and just stopping it, and it doesn't solve its purpose. So that is why my case selection is so limited, and that is why I use them so limited.
You give 200 BD, ma'am, yes, sir, for long term.
400 mgbd.
400.
400
Sorry, 400 BD. Sorry, sir.
400 mgbd.
Sorry.
Am I audible?
Yes, ma'am, you're audible.
Okay. Suddenly all the noise came down. Yeah, so now
Yeah.
we come to so now we come to the stromal disease. So here there are two kinds of manifestations. One is the immune stromal and one is the necrotizing stromal. So in the immune stromal, it is a type 3 hypersensitivity reaction. And necrotizing stromal is also has a component of direct virus invasion. So wherever we have a direct, we must understand the principle. Wherever we have a direct virus invasion, we must give topical ganciclovir or acyclovir. And in the other thing, you need not give. You may just go ahead with just topical steroids. Topical ganciclovir is not mandated in the immune stromal, but wherever there is necrotizing component, wherever you see that there is a component of melt or epithelial loss over the area of stromal keratitis, then you understand that it is due to direct virus invasion. In those cases, you must cover the steroids with topical ganciclovir or oral acyclovir. So this is the classical immune stromal. So you see them. So the epithelium over the lesions are intact. The margins are fuzzy, and they are fairly superficial, not very deep. Sometimes they can be deep, like this is a little more deep than these. These are all in different phases of healing, resolving. So the margins are fuzzy. So when the margins are not very well defined, you know that it is active. The patient, of course, will be symptomatic. Whereas you come to this, they're fairly well defined. So this is in the phase of resolution. So both are immune stromal keratitis. You
Ma'am,
can get
it's so
tubular.
familiar to the adenoviral. How do we distinguish?
Yes. Yeah.
The adenoviral will be smaller and they'll be like sort of very uniformly distributed. Like stromal, you can get very confluent lesions like this, where this portion of the cornea is relatively escaped. But in adenoviral, it will be a random distribution, and adenoviral can be very peripheral also. And adenoviral will not look so active. They'll be smaller. They'll be much smaller. And all of them will look like in the same phase, adenoviral, because they must have been triggered by one viral conjunctivitis episode. So all of them will be looking like in the same phase. Here you can see different levels, different sizes, and not all, entire cornea is not involved. So adenoviral has a fairly uniform distribution and it is more peripheral. Peripheral central bore, but more peripheral lesions also you can find. You can go up till here.
What
But
about
in
corneal sensations, ma'am? In stromal disease, sensations are there or they're lost?
stromal disease sensations, see, sensations per se is very, it's not pathognomonic of HSV keratitis. You do get sensation loss, but it is not pathognomonic. So, I don't know.
Ma'am, I have two questions, ma'am, here. One, ma'am, I have two questions. One is like, should we not call it nummular keratitis? Should we just call it immunostromal keratitis? That's one. And question number two, we see immunostromal keratitis due to adenovirus or due to herpes simplex. Is the treatment different?
Herpes simplex, see, the treatment will be the same. You will use steroids, topical steroids, but how they behave, what is the course, how indolent are they, that will differ in the way of treatment, in the trajectory. the treatment will remain the same, but the trajectory will differ. Like adenoviral keratoconjunctivitis, they resolve fairly well with topical steroids, 2 to 3 months, sometimes longer. And if longer, you can just go ahead with tacrolimus, and you can use softer steroids. Sometimes immune stromal keratitis may need steroids for a longer period of time, and the treatment must continue a little longer after resolution of all the lesions.
Correct. So,
Ma'am, is disciform keratitis is a further stage of progression of these infiltrates? Or is it a separate entity?
Disciform is another presentation altogether. So it is like a deep stromal kind. So disciform is another presentation of the same.
This will be more superficial stromal.
Yeah, this is mid stromal, superficial stromal.
Okay.
So you said, ma'am, the trajectory will be different. So for herpes, if it is because of herpes simplex, then the duration will be longer for resolution compared to adenovirus?
No, even if it does go, you have to continue the steroids for a longer time. So it's very important to identify whether it is HSV or whether it is adenovirus.
Okay. Okay. In case of simplex, we have to continue for a steroid for a longer time.
Yes.
Okay. Okay. And so do you add, mother, like if suppose we have to continue for a longer time, do you switch to tacrolimus plus weaker steroids, or you continue with something like fluoromethalone?
I continue with fluoromethalone, and if I see the patient's past history, if the patient has a tendency of recurrence, like he has been having a recurrent keratitis, then I tend to cover the tail end with the tacrolimus.
Okay.
Like when he has come down to twice a daily dosage, that is the time I put in tacrolimus.
Yeah, just sharing my experience with a very bad case, a patient of I don't know whether it was adenovirus or herpes simplex, but it was definitely immune mediated stomach keratitis, and the patient got CSCR because of the steroids.
Okay.
On the topic steroid at a very bad time, to telling the patient now you got a retinal problem due to my treatment, and but somehow he stick with me, and the CSCR went away, but the immune part stayed. And I didn't know of tacrolimus back then, but yeah, somehow it sort of died out on its own. But yeah, the obesity is remained.
Okay.
Ma'am, are these patients are at a higher risk of developing ocular hypertension or uveitis? The ones with stromal disease?
Stromal, see, deep stromal, if you actually look carefully, there will be some cells. So I think they go off with the topical steroids. So like all the layers are continuous. So if it is deep stromal, you will get some cells. But it is primarily a keratitis, less a uveitis. So it's primarily keratitis. So I think the steroids that we give will take care of the secondary uveitis associated with that. And long-term steroids, of course, you have to check the ocular pressures. You have to keep them under follow-up. You cannot just put them on steroids and leave them. Some of them have developed steroid-induced cataract and glaucoma. So you have to monitor.
Thank you.
That is one reason why put them on tacrolimus when like I'm lowering the steroids. So I put them on tacrolimus for about 2 months, 2 to 3 months. Because HSV will take a longer time to resolve. Like if you cut down the steroids very rapidly, they'll again reappear. Again, you have to go back to full dose of steroids. So those are the cases I put them on tacrolimus. So it'll be once daily, and then you have to again go back to 4 times daily. So those are the cases I put them on tacrolimus.
You're giving tacrolimus ointment, madam?
Yeah.
Okay.
So here you
So I
will
will
see
just one more question. Like I use tacrolimus on the lid, so you ask them to put on the lid margin or inside the eye?
inside the eye. I just ask them to put a little of it inside the eye, and then usually ask them to follow up after 2 minutes with the lubricating eye drop. So if at all they have any irritation, that goes off. And there are some patients who are very, very intolerant to tacrolimus, extremely intolerant. So those are the patients you should not persist. So either switch over to cyclosporin or else just put them on steroids. So
These, ma'am, I have found tacrolimus intolerant patients, you put them on LS, then they manage to use it quite happily.
Yeah. So LS depends on the kind of inflammation that you're seeing.
Right, yeah.
So that is also important. Like what is the kind of inflammation you're seeing? So necrotizing is again due to direct virus invasion. So here, like you can still see that the original pattern of the dendrite and the confluent dendrites is still maintained. However, you will see that there is a breakdown of the epithelium. So how these patients will come, like you'll be treating them for stromal and then they'll have a breakdown, and then sometimes they come in a very complicated stage and you'll be wondering what kind of infection is this. So they they're very desperate cases actually. So treating necrotizing stromal keratitis is takes a little time. So there will be severe stromal infiltration and overlying epithelial defect will be there. So these are the cases that I actually do not use steroids. I don't know. I do not use topical steroids in the initial phase. So I have seen that earlier I had cases where I used to use topical steroids and antiviral, and then I used to go into a web. Epithelial breakdown, then stromal is not coming down, again epithelium is not healing. Till I understood that unless you bring down the inflammation, the epithelium will not heal. And if I'm going on using prednisolone acetate, sometimes I do not allow the epithelium to heal. So what I do in these cases is I give them topical ganciclovir ointment 5 times daily, and then I put them on tacrolimus straight away, day 1. Then I review them after 7 days. Usually these patients do not go into that web of epithelial breakdown and necrosis. That is what I have seen. And once the epithelium starts healing, maybe about day 14, when the epithelium is fully intact, I put them on steroids, and I put them on fluorometholone. I don't put them on prednisolone. So this is how I'm managing, and they're doing quite well. I don't know. Anybody else has any experience on this?
Yeah, I like to share my experience. First of all, since I'm not doing microscopy or anything like that, so I have to make sure that this is not bacterial. Usually, you can bear the loss of corneal sensations and a very red-looking eye, and the ulcer isn't that bad. You can make out that this is viral. So what I do is I put them on Valcivir right away, oral Valcivir, Valicyclovir, 1 gram TDS, and 3 times a day, and along with the topical treatment, maximum lubrication, and 3 times Valcivir or ganciclovir ointment. And then I review them in 3 days time. Usually, like somehow I found out in recently 2-3 months that Valicyclovir in my hand, it is like working like magic. Within 3 days, the infection will definitely come down. And then I add oral steroids. I don't give topical steroids at all, for so many other reasons. So then I add, once I'm sure that it is viral, it's coming down, it's responding to antivirals, then I add oral steroids also. But in very like a dose of 20, maximum 30 milligrams daily. That's all. And they are doing quite well actually. I've got some very, very bad viral ulcers, some like really spoiled cases, and they've done really well. That's my experience.
Like how long do you use your oral steroids for?
Ma'am, both the oral steroids and the oral antiviral, for a duration that I see the ulcer is healing, the epithelialization happens, the maximum like 15 days, 3 weeks at the most, 2 weeks to 3 weeks.
Topical steroids?
Same duration, ma'am. I taper it off. Like I generally start with just 20 milligrams, bring it down to 10 milligrams, and once I see that the epithelialization has happened, the now the topical treatment is going to take care of it, then I stop both the oral antivirals as well as the oral steroids.
Okay, I have no experience with oral steroids here, but see, the main pathogenesis is that inflammation and infection, both are there.
Correct.
You have
Correct.
to deal with both, infection as well as infection. I have never used
Yeah.
oral steroids myself, but I don't further try.
In fact, for the immune variety, also some very desperate cases, I have used oral steroids, and if they are not doing well, even I've used prednisolone acetate, and if they are not even responding to prednisolone, then I give them for a very short duration. I give them oral steroids, and they're just like, ma'am, they respond to it. And after learning from you, now I'm putting them on tacrolimus also. So yeah, but like for a very short, like burst, like 5 days, 7 days, I give oral steroid.
Okay, so and how are they behaving tacrolimus?
Tacrolimus, ma'am, now, as of now, I have limited experience, only 2, 3 patients for like like 1 or 2 months. So they actually they don't bounce back. That is what I've noticed. They're not bouncing back. They're like sort of staying stable, and then I'm able to decrease the potency of the steroid. They're still staying stable, so I can say that the immune component is definitely taken care of with tacrolimus as well.
Only issue with tacrolimus is you can't use them for a long time. Like
Yes.
this is 2 to 3 months. I've
Yes.
never used them for a long time.
Okay.
Okay. So this is
One
one.
question.
Yeah.
In many patients with, stromal disease, disciform, uh, they are on ACVir 400 BD, and they come back where I've seen many patients coming back with dendrites. So is this a precursor to further? This is again an active infection which can go into this necrotizing disease.
Yeah, so like, see, the two things. One is the viral disease per se. So like when there's a trigger, you don't know what is the kind of manifestation that the patient will have. Since you are saying that the patient is already on a prophylactic dose of acyclovir, and on top of that he has had a trigger. So if he has a epithelial kind of manifestation, he'll have a dendrite. And if it is a stromal disease, then he'll have a disciform, like you said. So when he has a trigger, you don't know how he will behave. It's not that the dendrite will go into the stromal or into the
Okay.
disciform. They're like two different entities. So when there's a trigger, you don't know how the patient will behave.
What are the usual triggers, ma'am?
What are the precursors?
The triggers. You said if the patient is having a trigger. So what are the usual triggers?
Head study has already done this. There's one component of head study, heads 2. So they have
Okay.
studied sunlight and stress, and yeah. So the only factor that is has been proven to be the trigger is a prior viral infection. The others are all, there was no like conclusive data.
So you said stress, sunlight, and once what other infection did you talk of, ma'am?
Prior HSV infection. So that is the only known trigger. Any prior HSV infection, so that can trigger your secondary infections. Sunlight and stress, there is no conclusive data from the head study at least. So management of immune necrotizing stromal is similar to that, only that you must add topical antivirals, and using systemic antivirals also makes sense in some way, at least for a short period. And here you must make a more gradual taper of the topical corticosteroids, because here there is a lot of necrosis and lot of collagenolisis and melt. So the tapering of the steroids must be slower than your immune stroma. And endothelitis is a delayed T cell mediated hypersensitivity. So that can be a disciform, diffuse, or a linear. Most commonly we see the disciform. So here you are seeing like this is a classical disciform. This is also a disciform. So it's relatively well subscribed. and there's a noticeable absence of the leukocytic infiltration. So the disciform keratitis margins are relatively well circumscribed. The epithelium will be intact. You can get a microcystic edema over the area of the disciform keratitis because of localized endothelial pump failure for that period. And then if you must look for keratic precipitates, which will be pigmented and just beneath the area of the disciform keratitis. They will not be found elsewhere. They will be found beneath the area of the disciform keratitis. So here again, topical steroids, cycloplegics, and adjuvants. You must monitor all of these patients for any IOP rise.
Sorry, ma'am, what did you write in that second last slide? The edema is due to what? The immune reaction?
Localized endothelial pump failure, localized.
Correct.
That could be temporary, and if it is not managed well, it could become a permanent.
Dr. Ravi, you meant this only, this by disciform, or you meant something else?
Dr. Ravi?
Yeah, yeah. See, we see mixed patterns. Sometimes it's a mid-stromal severe haze. And then, when we see this decimates folds and these KPs, we know it's endothelial, but more of this second type, endothelitis. And they are on prolonged steroids, topical, and a severe BD. And then they come back with dendrites, a few patients.
No, but why are they on severe BD?
Sorry, ma'am?
Like, were they already
While they
on
are on ACV,
or they were
yes.
put on severe BD?
I have put them, yes. And then they've come back with dendrite. Means in a few patients I have seen.
Doesn't solve the purpose here, no? See, severe BD, if you're giving, that is for prophylaxis. That is not for treatment, right? And in this case, it is like more of hypersensitivity.
Right.
So this is not a direct virus invasion. So you don't need SCV for these cases.
I see. Okay.
Wherever you're using BD, that is for a prophylactic dose. That is not for a treatment dose.
Yes, ma'am. No, because that time they have been fine. They have come primarily with a stromal keratitis.
No, that is what I'm saying. So wherever you are giving acyclovir, it is either for a treatment dose or for a prophylactic dose, right?
Yes,
So
ma'am.
you're planning to treat a patient of HSV keratitis, whatever be the form, you must start 5 times.
Okay.
Or else, if you're giving for a prophylactic dose, it has to be BD, 400 mg BD.
No, ma'am, it is prophylactic because this has been going on, say, for more than couple of months. This topical steroid. So I start them, maybe that's what, am I doing a wrong thing? I start them simultaneously on 400 BD plus topical steroid to deal with the stromal disease, a stromal immune disease.
Yeah. So, but thing is, see, there are very specific indications for giving oral acyclovir. So there are few criteria that you must meet before you put them on dosing for prophylaxis. I'll come to
No, Dr.
Yeah.
Ravi, you are mentioning prophylactic to prevent the recurrence of keratitis, epithelial keratitis,
Yes,
or
yes.
so is this necessary? Because when you get it, then you can, you deal with it. But how does it
Right.
prevent viral keratitis, epithelial keratitis?
No, sir, it is more for resolution of the stromal disease to
That
aid the
won't require,
resolution.
you can do well with topical steroids or maybe a systemic steroid. But
Right.
how does antivirals, particularly oral antivirals, act in stromal disease?
Yeah, like ma'am is saying, I'll look into the indications more closely.
Yeah, if you have basically, why do you give a prophylactic treatment? Particularly, is there any indication of prophylactic treatment in this?
I was told by a cornea person to do it.
If your experience suggests that all the stromal keratitis people do present most often with a viral epithelial keratitis, And that is
No, this
what.
has happened in maybe 2-3 patients. That's why I was
Okay.
asking.
Okay.
Not regular.
Maybe in those cases, this acyclovir actually had nothing to do with that, because see, acyclovir prophylaxis you give for patients who are known to have recurrence, right? So I don't know exactly your cohort of patients, but for active stromal keratitis, I wouldn't put them on BD dosing. I wouldn't put them on oral acyclovir at all. So
Okay.
like when a patient is having a trigger and having a recurrence, that recurrence itself can manifest at different levels. So maybe your oral cyclovir has no role over there. It is just an isolated dendrite that has happened over a disciform keratitis,
Right. Yes.
which is very rare, but yeah.
Can I ask? Hi, okay, this is Shruti here. Can I ask a question?
Yeah, sure.
I have a patient who keeps coming at least 3 to 4 months just for regular checkup. And the first time I saw her, she had round, well-defined disciform lesions in the endothelial level. So I was, and the eye is quiet. So what is going on? I just call her for IOP checkup. And earlier I had started steroids for her, and they kind of decreased in size, but then I tapered it, and they're staying like that only now. And they are more in the inferior side. No KPs, no cells.
Is she symptomatic?
Sometimes she has this, foreign body sensation type. Like, that's all.
No, so a disciform or a deep stromal will not cause foreign body sensation. So what they will present is with a diminution vision, intolerance to light. So they will not have foreign body sensation. So if they have been there since long, you can actually look into the lesions individually. You might get viral footprints, you might get ghost vessels there. Look for them. And if the margins are very well circumscribed, like almost like a scarring of the endothelium, then you know it is a dead lesion.
Okay. So nothing much to do, just keep her under observation.
Just observation. And they are called the footprints, right?
Okay. Thank you, ma'am.
Patient is not symptomatic. I think they are just healed lesions.
I her saying that I have foreign body sensation. I took it to dry eye also, especially more in the time when season is changing.
See, it
that
could be
can
associated with that.
Okay.
Yeah, associated.
Okay. Thank you, ma'am. Thank you.
Yeah. So like head study. Anybody wants? So now let's go into the head study. So this is just a brief summary of the head study. So there it has got two limbs, head study 1 and head study 2. Head study 1 is complete. Head study 2 is also complete. Now, so in the head study 1, what they studied is on patients of HSV stromal keratitis who are already on topical trifluridine. They are not on acyclovir or ganciclovir. So it was a topical trifluridine, but they were not on steroids. So what did they compare? They put one group on steroids and they put the second group on a placebo. So steroids, the result was that this topical steroids will cause a faster resolution. And but the final visual acuity is the same, surprisingly. Topical steroids. Then HSV keratitis who were already on topical antivirals and prednisolone, whether adding any oral acyclovir to them in a treatment dose of 400 milligram 5 times daily for 10 weeks had any added benefit. So they put one group on oral acyclovir. This is like what I was like, Dr. Ravi, if you can hear this. So this is the second thing, that they put the patient who was already on topical acyclovir and steroids. They put that patient on oral acyclovir in a treatment dose, 400 mg/d, 5 times daily for 10 weeks. And they found no added benefit of oral acyclovir. So stromal keratitis, no added benefit of oral acyclovir. HSV iridocyclitis, When they added oral acyclovir 400 mg 5 times, there was a decrease in the treatment failure with oral acyclovir. So the treatment failure rate reduced when we added oral acyclovir. So it is worthwhile giving patients with herpetic uveitis with oral acyclovir 400 mg 5 times daily for, they put the patients on 10 weeks. I think we put them on 2 weeks. I'm not sure. Uveitis people, please tell me. Then herpetic eye disease limb 2. So this happened later. So patients on HSV epithelial keratitis trial who were already on topical trifluridine, whether adding any oral acyclovir in a treatment dose had any benefit. So it had no advantage. So epithelial keratitis, no added advantage of oral acyclovir unless the patient is intolerant to a topical application or has a neurotrophic component like we had discussed. Other than that, there is no added benefit of oral acyclovir. Then HSV acyclovir prevention trial, a past history of keratitis within 1 year, oral acyclovir 400 mg PD for 1 year versus the placebo, there was a 41% decrease in the recurrence and a 50% decrease in more severe keratitis. But we must remember that this was during the treatment, during the period of prophylaxis. Beyond that 1 year, once you stop the prophylaxis, again the patient is equally prone for both. But only thing is that for a 1 year period, you can get out of that infection inflammation cycle. Then HSV risk factor study, the risk factors evaluated, they have not mentioned here. One was sunlight, the other was stress. Then the prior history of any epithelial keratitis. The only known risk factor which had any conclusive result was any history of epithelial keratitis. I have a bad throat. So treatment, when to stop and how to follow. So this is important. Topical steroids are continued after clinical resolution and asymptomaticity. So even if the patient has clinically resolved and is asymptomatic, steroids must be continued further, a little further than that. Steroids need to be tapered over a prolonged period, sometimes months. And during this, the patient must be counseled about follow-ups and the need for IOP checks. And they must be also made aware of the symptomatology, like intolerance to light or a drop in vision, all these things. Follow-up in recurrence is to be timed around the previous interval before recurrence. Like suppose the patient had a recurrence after 3 months. And then the patient has had a recurrence and you have been treating the patient. And the patient is now resolving. So the next follow-up should be around 3 months. So that if at all there is a recurrence around that time, you will catch the patient at the time of recurrence. So every time, whenever I plan or I find a patient who could be a probable candidate for oral acyclovir, I always study the interval between the recurrences. Like if the interval has been increasing, like once is 3 months, then it has gone to patients, I really do not put them on oral acyclovir. Only patients who are very compliant and in spite of a very good compliance, they have recurrence, or else they have other issues like they have to undergo a cataract surgery at some point of time. Those are the patients that I put them on a prophylaxis.
Ma'am, sorry, one question here. Do you, well, like, if suppose you're treating the patient with fluoromethalone and the patient has resolved, so do you continue your long meticity and post-resolution with fluoromethalone only, or do you switch down to lotriprednol high dose or high strength or your low strength?
No, I use fluoromethalone, and when I'm tapering fluoromethalone, like suppose the patient in the last recurrence had a resolution in 4 weeks from the records.
Okay.
I'm a patient under my treatment. Suppose the patient had a resolution in 4 weeks, but had a recurrence after 3 months. Like this is a very situation specific thing. So when the next time he has a recurrence, I will maybe put him on steroids for maybe 6 to 8 weeks and then follow him after 3 months.
Okay.
And if I have to put him on steroids for a longer time, like he has been on steroids for maybe 6 months in a year or 4 months in a year, those are the cases, or like nowadays, most of my cases, when I'm bringing down the steroids to twice daily, that is the time when I introduce tacrolimus. And then twice daily, once daily steroid stops and tacrolimus continues BD for 2 to 3 months, again depending on when was the patient's last recurrence interval. So that is how I'm managing.
So how do you taper? Do you taper from 3 times to twice to once, or and then alternate day, or how do you exactly taper? What is your regime for tapering?
I don't do alternate day. Suppose the patient last recurrence like on a 10 days treatment, 4 times 10 days, 3 times 10 days, then the patient had a recurrence after 3 months. This time I will put the patients on 4 times 2 weeks, 3 times 2 weeks, 2 times 2 weeks, once daily 2 weeks. When the patient is on 2 times starting, that is the time I will introduce tacrolimus.
Correct.
That 2 times 2 weeks, once time 2 weeks stops. Tacrolimus continues that month and 2 months more beyond the stopping of steroids.
Okay. Okay. Thanks, ma'am. This is very clear now. Thank you.
Ma'am, fluoromethalone is preferred to loteprednol.
Yeah, not preferred, it is my preference. In HSV, I don't find any point giving loteprednol. Loteprednol is a very soft steroid, surface acting. So HSV, I do not use prednisolone, I just go for fluoromethalone. In adenoviral, I go for loteprednol. And I add asteroid.
Any experience with this loteprednol high strength HS from micro?
I haven't used.
Okay.
Penetration of fluoromethalone is little more than loteprednol, is it?
Yes, yes.
Okay, I was not aware.
It's more a surface acting, loteprednol. So you see, there are doctors who have started patients of uveitis with loteprednol. It's not going to solve any purpose. Very little intraocular penetration.
Very nice.
So what are the complications that you could come up with is herpetic epithelial disease, like Dr. Ravi was saying. He has patients of disciform who develop herpetic disease. That is because of the steroids that they use. And then indolent metaherpetic ulceration, stromal ulceration melt, neurotrophic that we discussed, secondary glaucoma, then stromal neovascularization and secondary microbial infection. This is very important that we must rule out secondary microbial infection. If at all a patient was improving and then suddenly worsened or the epithelial breakdown happened, then you must differentiate between a neurotrophic ulceration or a stromal necrotizing ulceration or a secondary microbial infection. So scraping is a must. And before you scrape, just look at the margins of the ulcer. Like secondary infections, one is fungal because the patient has been on steroids. That is one. Fungal infections, if they present early, patient may not be very symptomatic. In fact, they may not be aware that they have a secondary infection. Secondly, I haven't seen bacterial infection secondary. Mostly they're fungal. And hypopion in a case of viral keratitis. It's very rare unless it's a keratouveitis you are treating. Otherwise, hypopion in a case of viral keratitis is very rare. Whenever you see hypopion in a case that you had been treating as viral keratitis, then scrape. It could be a secondary microbial infection. So hypopion is not common. So whenever you see hypopion, scrape. Yeah, so this is about viral keratitis. So should I go to the next one?
Yes, yes, please do.
Yeah. This is something that how do I enlarge this? How do I increase the size of this one?
Double click on the picture and then I think that should do.
Yeah. So
Or
this is like we are going into VKC.
okay.
Yeah. Yeah. So this is a patient of VKC. It's a burnt out disease. So it's not very clear because he was very symptomatic. He's a young boy. He's now giving his +2. So here you can see that there is total limbal. When he had come to me, he had come in this stage of complication. Like he has been under my care now for about 7 to 8 years. So he had a total limbal stem cell deficiency. He didn't have any papillae, GPC, nothing. Whenever he has any flare up, it is always a limbal hypertrophy. It's always a limbal hypertrophy, and gradually in time, he was lost for follow-up for a period of 6 months. And then when he came back, is this pannus kind of thing. He had a huge pannus kind of thing in one eye. And this was all that I could see of his eye. And he was quiet and he was happy with his vision because he was having some kind of a pinhole effect. So this is the picture. Now how I may go back to the other one.
Ma'am, click on the arrow on the, it's written yes there. Click it back.
Okay.
Yeah. And double click on only the photograph.
Yeah.
Double click.
Yeah. So this is how he came back. And that time I was a little worried. What if he loses his vision in this side? Because that time he was going to give his 10th. And then this is what I saw when he had completed his 10th. Same eye. So this had given him, here in fact the vision had dropped. Because here you can see that this pannus has come to almost 3 millimeters of the pupillary area. And there was a very thin layer of epithelial hyperplasia, even in the clear, which was not covered by the vascularization. So here his vision had dropped.
Dr. Sagar, can you mute yourself, please? Yeah, thank you.
Yeah, so this is one case where I actually didn't know what to do. So with his consent and informing his parents, other than referring him to some other place because they didn't want to go anywhere, so I just took him up for a pannus excision. So the same eye is doing pretty well. Every time I measure the area of pupillary area of cornea, that is clear, and he's holding quite well. So maybe I'll do the same treatment for the other eye, even though his pupillary aperture is not, the corneal clearing is not as small as this eye. So this is one very complicated case of VKC.
So is slit possible in such a case, ma'am?
Slit will not be possible because this is a bilateral disease. He has LSCT in both eyes. So slit will not be possible. So if at all, we have to go for allograft limbal stem cell transplant. So that again has its own cons. So he's a young boy. Now he's completed his +2. So he's a young boy. He'll have to be put on a lifelong of immunosuppressants. So I just
pardon my ignorance. What is slit?
Simple limbal epithelial
transplantation.
Ma'am, when you do this pannus excision, is it easy to get a plane of dissection to remove?
It wasn't very easy, but it wasn't that bad either. Like it was
Good question.
It wasn't that bad either. Like this
So
is
I guess the lesson is we should not sit idle. We should try and do something. The lesson is this.
Not like your lime burns and all, because there it goes into the corneal tissue and everything. Here it was not like that. Here it was not like that. Like though I didn't get a plane through which I could pass a blunt dissector or something, But this wasn't that bad because there was not too much of corneal invasion. Wherever there was a corneal invasion, like here, I just stopped there. I could remove up till here. So like this was a patient who had come in a very complicated stage to me. So this is one of that. We should aim that a patient should not go into this. So whenever I do not put the patients on long-term steroids, but every time you have a recurrence, we must remember that exacerbation, not recurrence, exacerbation. I feel it's very important to take care of the limbus. Like whenever you are seeing that there is a limbal hypertrophy every time, like HT spots, anything that is happening around the limbus, in those cases, I put the patients on steroids at least for that phase of exacerbation, at least for 1 month. And then I continue them on disodium promoglycate. Disodium promoglycate does very well. And if the patient has associated dry eyes, then I go for cyclosporin. Or rare cases, I go for tacrolimus.
Cyclosporin can be continued longer than tacrolimus. Safety profile is better.
Yes, yes. Cyclosporin, 6 months you can easily use. There are patients who are there on 2 years cyclosporin. I have not seen any kind of epithelial toxicity or endothelial toxicity. Beyond 2 years, I have not put anybody on cyclosporin. Sometimes what I do is if the patient is stable, then I give them off periods. I switch off from cyclosporin. And then after some time, again, if they have a bad flare-up, then again I switch off. Otherwise, disodium promoglycate does well.
So it is better than all these other now antihistamines these companies keep flogging.
Yeah.
Okay.
Only issue with disodium promoglycate is it's not very plentifully available. Only this Cipla has.
Cipla.
And there is another company I'm forgetting, but I have not used it. There's one more company that he has a 2%.
Albalon needs to be there, no?
Uh-huh.
Albalon, one brand name, long back.
There's one more. I don't remember.
Albalon they used to call.
Okay, so that only issue is the availability, and the second one is you must counsel the patients that they're not to stop it for any period of time. Like suppose they have stopped it and then they have a flare up and then they use it and it doesn't work, then they just say that it doesn't work and then they might change the doctor and might be just lost for follow-up for you and they'll come back to you in a bad state. So you must counsel them that this is for a prophylaxis. This is not for treating any allergy. Like they should not stop and then again start when they're having a red eye.
Ma'am, what is your experience with
And
the
most
nicotastin and alcaftidin and all these new drugs like Dr. Ravi was saying?
I have not used them long term for any patient, but yes, like patients who have like this very seasonal allergy, who have got no history of allergy before. So those are the patients like who I know I'll be using only for these 2 months. Those I use, but I don't use them for VKC.
Okay.
Ma'am, which of these newer anti-allergics do you find is the most promoglycate sodium?
No, sodium promoglycate, I don't use them for seasonal allergies. That is only for VKC and like people, only for VKC. I don't use them for seasonal allergies, not even for contact lens related papillary conjunctivitis. I don't use them for that.
Right, ma'am.
Sodium promoglycate, I only reserve it for VKC patients. And for
Right.
patients with acute allergies or just like a seasonal allergy, those are the cases where I can go for Bipavacin. If they have large papilla, I even go for a loteprednol for 1 month and stop it.
Right, ma'am.
And cold compress protective glasses, that is a must. That is like written on my prescriptions.
Right, ma'am.
So this is about VKC. There's one more. This was an interesting case. I saw her just last week. So this is how she had come. Yeah. So this is a young lady, 35-year-old. She said that she had foreign body sensation for about 2 months. So when I saw her, and she was very symptomatic. So when I saw her, I saw a large nodule here, a granular kind of thing, very vascular, and it was raised above the corneal surface, and it had a gelatinous appearance. It's not very clear here. And there was a breakdown of the epithelium just ahead of it. And she had a hypopion. So any thoughts how to go about it? One eye, the other eye was normal.
I think
And
I'll
yeah,
resort to some scraping and then a lot of lubrication and atropine. And if it is the cornea is looking really thin, then maybe tremolol also.
no. So what is your diagnosis?
Could there be a foreign body in this?
Medicamentosa, ma'am. Maybe medicamentosa. No, I'm not sure. Like these deposits, what they are appearing is very white and nodular deposits.
No, this is a raised lesion. And there's a breakdown here. So what is your thought? What is the mechanism of this ulceration, or what came first?
Tumor is invading within the AC, and that's a pseudo hypopion, is it?
No, that is a hypopion. That is a hypopion. I did this ASOCT was not possible. She was very, very symptomatic, but no, through the sites I could know clinically that it was a nodular lesion on top, and there's a ulcer ahead of it. And there was some this deep stromal infiltration and exudates, endoexudates.
It's a neoplastic lesion.
And how did the infection and the neoplasia coexist?
Ma'am, she had a trauma history?
No, nothing. She just said 2 months she had a foreign body sensation. And then since 15
But
days.
she didn't have a foreign body in this.
Secondary infection.
She gives no history. So it could be a direct invasion of this, whatever is this mass. It could be a direct invasion, and what we are seeing is an invasion, and could be a pseudo hypopion also. So my thoughts on this was this is a raised tumor, and this is causing a Dellen effect. Okay, so because there is a breakup in the tear film ahead of it, that area will be prone for ulceration. So she has been having this since 2 months, and now that she has had an ulceration, then she's complaining of pain. So it could be due to direct tumor invasion, or it could be just a Dellen effect secondary to the tumor. Suppose you had a pterygium instead of this tumor here. Suppose you had a pterygium that was coming in up till here, and then you had this ulceration ahead of it. So that is how it is behaving like a Dellen. So there will be a breakup of the tear film just ahead of that raised lesion, be it a pterygium head, be it a tumor, be it a suture, be it any irregularity on the surface, like a graft post junction is raised in one part. Just inside of that, you see that there's a epidefect. So that is called a Dellen effect. So in fact, I've taken her up for surgery. So this is on the slit lamp. She was not very cooperative, but you can see here. Here the beam is raised, and here there's a crater kind of thing. This is just at the margin of that. So just ahead of that, there is a breakdown. And then it could be secondary infection post ulceration.
Ma'am, does this thing hypopion, it looks like bumpy, is it? In the picture.
Yeah.
Looks tilted as well. I mean.
Yeah, it could be anything actually. So I did a scraping just to rule out an infection. Now scraping showed fungal filaments, and voriconazole, and I have put her on sufficient lubricants. Then I took her up for surgery, where I did a epitheliectomy, and I just removed this mass. It came off pretty well. Like, it was not clinical, didn't look invasive to me, but I can't say for sure because one margin is into the ulcer. So I can't be very sure whether it has invaded that area or not. But this area, it came off pretty well. Just with alcohol epitheliectomy, it just came out well. In fact, I removed all this epithelium and then I put a tenons and a AMG. So I've sent it for histopath. Then I'll see what is to be done. So this is one. OSSN, you have to be very, very, clinically aware that this could be OSSN. So sometimes even pterygium heads can have any epithelial hyperplasia. Or Dr. Ravi had shared 2 cases in the evening today. Yeah. So Dr. Ravi, if you could just elaborate on your case. I'm just sharing your case. So this is case 1. Dr. Ravi is there?
Yes, ma'am.
Please
So
elaborate.
this was a 54-year-old lady. She came to me with, this was in end 2019 or beginning 2020 with little discomfort, pricking. And, I saw this kind of superficial leash of vessels with a little, lipid infiltration. In fact, I had sent this image to one of my friends who's a cornea person. And he was insistent on viral, but it didn't look. So I just kept her on lotiprednol, lubricants. She improved. She came back once and then she never came back again. So then, ma'am, the second picture is when she came back to me. This was about 3 weeks back. So this was what then I thought that this could be an OSSN. And just inferior nasal. It is, now as you can see, it is concentric with the limbus, elevated. So I started her on topical mitomycin, QID for 1 week, and then that 2 weeks off. That I have had quite a few patients whom of course, nothing like this, but where you see something like a kind of a pinguicular type of lesion, little lipid at the limbus, but the whole surface, if it comes back, and I have treated them with mitomycin with wonderful results. And so I have tried with her. There is some resolution now. I've given her the second cycle. It's like 1 week and then 2 weeks off, and then again 1 week, 2 weeks off. So now I've just given her the second dose, but I have not found much improvement at all. I mean, minimal compared to the dramatic improvement I have seen with other patients where it is very localized. Say, like, what I saw in the first picture, how it was. So is it an OSSN?
At the outset, it doesn't look like OSSN to me. This initially, if you go back, so when you go back to this picture, see, this is a marginal lesion, right? This is the only, this area is there, right? This is the only area, I think. This is the marginal lesion. And with the feeder blood vessels here. And you said it's not raised, it's more like an ulceration.
No, it was raised, ma'am. It is definitely raised. That was what,
No, but you had lipid deposition, right?
Yes.
And fluorescent staining, it took stain?
No.
It didn't take a stain?
No.
What about the staining now?
No, I have not stained because it was so grossly elevated, so I did not stain. But she will come back, then I can.
So what I see here is like, this is a pannus kind of thing. Okay. This is like a pannus kind of thing. So now what is happening, if you, I don't know, I don't have the split picture here, but what I can see here, like there is a breakdown here. And since it has been chronic, so this is more like a PUK. This is more like a peripheral ulcerative keratitis. And if
Like
it
a
is,
Muren's kind of similar picture.
Murens will not be like this. Murens will have
Muren's will be
margin
excavated.
from limbus, excavated, and it will have a clear margin from limbus. Murens will
Right,
not
right.
be like this. The second thing is Murens will usually begin nasally, temporarily, and then go like this. Murens will not go like this.
Okay.
And secondly, Muren will be excruciating pain. No
Yes,
pain, no
ma'am.
Murens. Okay, so that is point 3. Third part is it's more like a PUK. So I was actually looking at the lid margins in your patient. You can see a lot of pneumonitis here. You see
She
this?
has.
She has a lot of pneumonitis here. So this patient, why she responded to your MMC in the first few days is because you gave her a immunomodulator, MMC. Okay. But if you had given her a steroid and an antibiotic combination, so it would have solved the same purpose instead of giving MMC. So in this case, what I would do is, if at all there is any ulceration, I would like to scrape and see. I wouldn't find anything much. And the fact that you're finding something like lipid, it shows its chronicity. Okay? Lipid degeneration, everything happens in chronic lesions. So it's a chronicity. So OSSN will not last this long in this way.
Okay.
This is more like a PUK. And since the first area of ulceration or the lesion was here, it is more likely where it was in contact with the lower lid. Lower lid contacts will usually happen at 5 o'clock, 7 o'clock, not at 6 o'clock. So at 5 o'clock, 7 o'clock. So
That's
most
where it has
was
started.
at the area of lower lid contact. And then since she is having now a formed pannus kind of thing, so there is a course of epithelial breakdown ahead of the pannus, and then infiltration, pannus infiltration, more like infection. Okay, low grade infection. So I would treat her like a PUK. Maybe I would take care of her lid margins. Just check the other eye if there is any scarring there in the periphery. Just look at the other eye. If she has any scars in the margins, like exactly which areas I said, just see if she has any scars there. If she has scars, that means she must have had some minor episodes which she is not aware of, and that goes more in favor of your lid margin infection. What is her age?
55.
55. And just take
And
a
ma'am, first, I'm sorry, I didn't. For 1 week first, I had given a loteprednol with lubricant. There was no response. Then I started with added MMC. I did not stop the loteprednol.
MMC is stronger than loteprednol. In these cases, I would go for fluoromethanol.
Right.
Fluoromethanol and maybe a tobramycin or some other antibiotic for coverage. But what I would rather do is take care of the lid hygiene, doxycycline, lid scrubs. That should do better. And because she is having now a raised pannus kind of thing here, she will need a lot of lubricating drops. And then gradually you will see this, once it starts scarring, this over the cornea appearance will also come down. It will become atrophic over there.
Okay.
She will have a lot of astigmatism. So I would rather treat her in the PUK line.
Sure.
Investigate if she has any systemic conditions, but I can see her lid is not very hygienic. I can see the meibomian paste-like secretions here.
Okay.
Any other thought on this, anyone?
Dr.
What is your
Ranjini has a
experience?
question.
Yeah. Hello.
Hi.
Hello. Am I audible?
Yeah.
Yeah. Ma'am, what is your experience of interferon alpha 2B drops in case of OSSN, ma'am?
I have not used. I always go for MMC.
Okay. Thank you.
And Yet another case. This. So like this is, I think, essential thorn injury, right?
Yes, ma'am. So this was just out of interest. This is the second time a patient like this came to me. He had a thorn injury, and you could see the track. And this, of course, in this case, he has come to me 25 days after the injury. But the earlier patient, the track itself is not, there is a little infiltrate, but at the endothelium, you can see a, blob, raised, elevated infiltrate into the protruding into the AC. So I was really at a loss what to do because this patient has been treated with uh, moxifloxacin, natamycin, voriconazole, and in fact, the treating doctor gave intrastromal voriconazole injection also. And he is a young boy. He was 6'9" vision, but just main complaint was photophobia on reducing medicines. So since he's already on all these things, I've just seen him 4-5 days ago. So what I did was I scraped the surface of the lesion, gave him natamycin plus voriconazole plus ketoconazole and getifloxacin 0.5% 4 times a day. And ma'am, that other picture, which is now 2 days later, he's come. In fact, he came last evening. So there is a little whitening, and I keep calling him to scrape now every 2 days that, so that, but one thing is that, it's so deep into it's right, that infiltrate is protruding into the AC. And what, just anyone's thoughts, what can I do? The first time when that patient came to me, virgin case, untreated, he responded extremely well, very quickly, and did very well with repeated scraping and antifungal. This patient, since he is, I'm just scared that I hope he's not resistant.
No, see, you can clearly see it's resolving because you see the margins here. Here there is a little bit of fuzziness. Look at the margins here. Fluffy white, right? But you go back to your next picture, the last one that you showed.
Yes.
Now see this. Fuzziness has come down here and the margins are fairly more regular here. And is this the endoexudate that you're talking of?
Yes, ma'am.
Yes. So now you see the area of the endoexudate is much lesser than the area of the superficial ulceration and scarring. So that is one indication that it is responding to treatment. So it is not a fresh endoexudate that has appeared, but the endoexudate that is now lesser than the area of your ulceration. And you see the margins are getting better. Hopefully a patient also must be feeling better.
He's comfortable, ma'am, because of probably the hometropine. No, but the photophobia would have been there with hometropine also. He is symptomatically much better.
Much better. See how much he can open his IPF. Everything will tell you whether the patient is getting better or not. Sometimes you don't ask the patient. When you see your patient walk into your clinic, no, just ask him to remove his glasses. So sometimes I just ask them to remove their glasses. I don't ask them anything. So how much they can open their eye, that tells me whether they're responding to treatment or not.
In fact, ma'am, he had such few symptoms that, that's what prompted me to think more of fungal because, he was just complaining of little photophobia, but he was worried that it's been, 25 days and it's not healing. So what's happening?
Did you get fungus on scrape or you didn't do?
No, ma'am, because that infiltrate is right protruding into the AC. So, I'm just scraping little superficially just the epithelium. I'm not going because that full thorn tract is there.
Yeah, so this is the epithelium, right?
Yeah.
This is the epithelium and this is the endoexudate, right?
No, this whole thing is the endoexudate. Epithelium, it's a sealed tract. I had to scrape
This whole thing is endothelium. Okay. So
this is only on the endothelium.
Yeah, so but even then, even if it is endothelium, just see the margins. You can compare. See, look at this.
Yes, it is looking, it has become white, you know that it is, you are right.
Exactly. There is whitening. So since there is whitening, is this your previous picture? Yeah, you see this.
3.
So there's a little bit of whitening, and then you see here it is less dense, and the density is maximum here. Here it's losing its density. So that is one more sign of resolution. First is your patient comfort. That's not always reliable, but if you have been seeing a patient in series, you can know. Patient comfort, then the lesion size, the lesion's margins, as well as the density of the infiltrate. And since it is endoexudates, so that will take a longer time. It will not resolve in 2 to 3 days.
Right.
It will take maybe 2 to 3 weeks to go into complete scarring. So in this patient, you put homatropine if the patient is comfortable. I wouldn't mind putting on atropine also. So you can put homatropine if that is okay. But see, if it's a question of losing one eye, I don't want to preserve his cycloplegia so that he'll read his newspaper. So in these cases, I would rather go for atropine from the beginning. And then I feel he's resolving. So you can put him on voriconazole better. If the epithelial tract is very small, then you put him on voriconazole. That has got better penetration.
Right.
That epithelium. So I would put him on voriconazole maybe half hourly or 1 hourly. Half hourly, since it's more of endothelial. So I would put him on half hourly, let's say 20 times a day. Then atropine and put him on oral antifungals for a longer time. And since you're seeing him in 2 to 3 days, now he's getting better. Now increase the interval, make it 5 days so that the difference is visible. Either he'll worsen or he'll get better.
Okay. So it's not mandatory that every alternate day we keep scraping the epithelium because it heals, it's healing over.
In your case, there is nothing, no, it's only a tract, you said.
Yes.
So the entire thing is endothelium.
Yes.
And if I see that there is any, you keep measuring this, and if I see that there is any increase on maximal medication, then I will go for intracameral voriconazole.
Okay.
Intrastromal won't help here. If you have to go, if you have to be decisive, then you have to go intracameral.
Okay. And somewhere I had read that that's why that you use natamycin plus voriconazole together. Is there any rationale? I've read it somewhere. It works more, it's more effective.
I go for one.
Okay.
So it's more about patient compliance and for what purpose you're using it. Natamycin has very poor intraocular penetration if the epithelium is completely healed. So in those cases, you need to debride. Since you don't have too much of an epithelial component, so there's nothing much to debride. And you have to go for intracameral penetration, then you go for voriconazole.
Right.
Go for one drug. Because natamycin anyways does not have too much of intraocular penetration in this case.
Right.
I think it's resolving. In 2 weeks' time, this will become a scar.
On the group, I'll keep updating. He comes every second day.
You can measure that infiltrate, no?
Right.
Okay, so I think I have this much for the day. Any more things you can ask?
Ma'am, thank you for the wonderful class. Ma'am, one more question. In case of neurotrophic keratitis, if it is a surgically induced, So it's like a permanent neurotrophic keratitis. What is the management, ma'am, in that case?
Yeah, again, depends on the location. Like suppose sometimes after post RT radiotherapy or post any lead surgery, in those cases, tarsography is a must. Tarsography is a must. Sometimes like patient will have any scarring ectropion or something, and that might be causing a neurotrophic keratitis. Then you have to close that lid aperture. Without a tarsography, even a BCL will not hold. And if at all that can't be done, then temporarily you can give Botox injection. You can give Botox injection or an AMG. But the only thing is, even if you give an amniotic membrane, then that is supposed to get absorbed in 2 to 3 weeks. So what do you do beyond those 3 weeks? So you have to see like what is the permanency of that lead defect or whatever.
Okay. Because I
Ma'am,
had
one
one
question.
patient who underwent neurosurgery. So that was a surgically he had lost sensations all over the face. All the fifth and seventh nerve was involved. So is there any chance of again getting back the sensation in those conditions, ma'am?
Very rare. I don't think so.
So in that case, like we should just put him on lubricating and immunosuppressives like cyclosporin will help in those cases for a longer time.
Do a tarsography. Tarsography, do a permanent tarsography there. Tarsography will actually, that works the best in such cases. So do a tarsography. In addition to that, you can give lubricating drops and put him on ointments, more than drops, bedtime ointments, nighttime ointments. And cyclosporin, I don't know. I don't think it has any role here.
And what is the rationale of using Botox?
No, that is what, if it is the like patient had never had, suppose patient has had a surgery since long and had a lag of thalamus. He has never had a ulceration before this, but he has suddenly developed an ulceration, which you expect that can heal, is responding. You can either do a tarsography there, or else if the patient does not want a tarsography, you can do it for a temporary 2 to 3 weeks so that the ulcer heals. Then you just
Caustosis. Okay.
caustosis. So give a Botox, and then Botox will buy you time. In 4 weeks, 5 weeks, the ulcer. Any kind of keratitis.
Because this is what they told me, that for us, suppose there is an immune keratitis or an and where we are, using these topical steroids for a very long time, that acyclovir is protective, or it will prevent the recurrences. But unless we are seeing the recurrences, we should not start. Only if we see recurrences, then we should start.
The recurrence, see, there are certain criteria. See,
Flare-ups.
Suppose a patient has a recurrence in January, had an episode in January, now has an episode in October. So it is treatable. For that kind, see, you must always weigh the pluses and the minus of that systemic acyclovir that you're giving, right? And it is not something you can stop in 2 months or 3 months. Minimum 6 months, then you can continue up to 1 year. And you have to also calculate the cost. Acyclovir is very costly, not affordable to most of the Indians. So whenever you're discussing a prophylaxis, you must always keep the cost factor in mind, because sometimes the patient will say yes, but the patient is a farmer, may not be able to afford a cyclovir twice daily for a long period. So all these factors should be taken into consideration, not that just what we should not go by the rule, because they might start but stop in 2 months. Then what happens? The farmer, poor thing, has essentially lost out on that much of money without any added benefit. When you're
Right.
putting somebody on prophylaxis. So when you're putting on prophylaxis, it has to be, suppose a one-eyed patient, vision threatening, those are the cases where prophylaxis will be first on your mind in case of recurrence. If the patient has recurrence because he has been non-compliant, has not followed up when he was lowering his medications and then has a recurrence, when you can't differentiate between a residual infection and a recurrence, those are the cases you hold back on the prophylaxis. But if the patient is very compliant and you know that in spite of being very regular on his follow-ups on medications, still has recurrences that are affecting his quality of life, he has to visit you very often, those are the cases you put on prophylaxis. So many other factors when you are thinking prophylaxis. I always
Okay. It
see
should
the,
not be a blanket usage.
yes, I always see the cost of that medication that I'm giving the patient. And then twice daily for at least 6 months. So calculate the cost. If that doesn't look affordable to me, it won't be affordable to any normal person there. I wouldn't spend that much and be told after 2 months that it is no use. So you have to see so many factors. That is why I said, no, if I have 100 patients of herpes HSV with me who have been there with me for 3 years, 4 years, 5 years, hardly 2 or 3 will be there on prophylaxis. There's so many other factors. Like if patient has a recurrence, had one in Jan and had one in October, 10 months, it is okay. Not a big deal. So in that patient, I'll not put him on prophylaxis. If a patient has in Jan, then I stopped medication sometime in March beginning and had a recurrence in June. Again, I will put him on treatment. Next, I will try to increase the or taper the steroid for a longer period of time. Put this patient on tacrolimus so that Jan to June was 6 months. Say March to June was 3 months. He stopped RX in March. So 3 months. So next time I will see that. Let's June, I'm starting his treatment. I will continue to, let's say, August, September, maybe even October with tacrolimus, so that the next recurrence is not after 3 months of stopping tacrolimus. The next recurrence will be after 6 months of stopping tacrolimus. That is why when I study his case file, I will know that the recurrence is also becoming far between. Those cases, again, I will not put on a acyclovir.
Right.
But if that patient has been following up with me, and every time you see that 1 month after stopping RX is every time having a recurrence, or like he cannot come to hospital that often, those are the patients that discuss the treatment and I'll put him on acyclovir. You don't go for prophylaxis without discussing treatment, right? So many factors I keep in mind when I put a patient on prophylaxis. So that is why I'm not a very good prescriber of oral acyclovir.
And ma'am, one again, that it's not necessary like if for a stromal acetate, we can try fluoromethalone first.
Yeah, I always give fluoromethalone.
Okay, I will do that now. I use more of pred acetates. Maybe that's why they are coming back with these epithelial dendrites.
Yeah, pred acetate, I find they have a higher potency to cause glaucoma, steroid-induced cataract, as well as more propensity for epithelial breakdown and secondary infections.
Right.
Once I'm using the highest drug, I don't have anything else in my reserve. So I always go for fluoromethalone. Fluoromethalone 6 times. I don't think any other drug is needed more than 6 times in HSV.
Right.
Can I add one point here? Like if you put the patients on Predfort, it works like magic. You just go away in 2 days, the patient will be very good, very comfortable. And once the patient knows, and it's so cheap, once the patient knows that this drug works like magic, you tell them 1,000 times don't use it, they will keep on using it. They will use it off and on, off-label use. So that is why you end up with all those problems. Ma'am, I have one question. So whenever we see a case of immune stromal keratitis, so is it always preceded, though we may not have seen it, is it always preceded by an epithelial ulcer, by an epithelial disease, or can immune disease happen without any epithelial disease, without any ulcers?
It can happen without any ulcers also. He must have had some episode of HSV infection sometime back. Some infection, like sometimes they feel because of fever we had these ulcerations. So they won't associate that with your ocular infection. He must have had some form of HSV infection, and then this is a result of a trigger of that infection.
So any sort of a HSV infection can lead to an eye disease actually.
Yes.
Ma'am, I have two questions. Yeah, one is do you use mitomycin C eye drops in conditions other than OSN? Like supposing we have operated a pterygium in the primary time case and not used any extra medication, normal we have done with an autograft, and now we see an early recurrence of the pterygium. Would mitomycin eye drops help there? My second question is in the cases of those viral keratitis where you're talking of oral acyclovir, I have a cornea person with us and who tells we had a case of viral keratitis HSV which had a secondary infection, so we had to start antibacterial medication for that patient, and what the cornea consultant did that he withdrew the topical is antiviral and started oral antiviral, saying that one of them is enough. You don't need to give both the antivirals, topical and systemic. Any clarification, your opinion on that?
Like how long into the viral infection did the patient develop a secondary infection? That is important.
Actually, the patient was taking treatment elsewhere. So when the patient came to us, there was already a secondary infection. I think it was a 1 week or so. 1 week. It was 1 week, I think.
1 week viral going into secondary infection is very unlikely. Very unlikely. So first of all, you have to be very sure whether it was a viral in the first place or not. Like what made you think that it was viral?
Because that patient had some satellite like other lesions also which were having a dendritic pattern other than the main lesion.
Exactly. In those cases, and what was the secondary infection? Did you scrape? Like, was it fungus or
Yes, yes. It was, I think the report later on, we first thought it was only bacterial, but later on the report came of it being fungus.
Yes. So those were not the dendrites. Those were the pseudodendrites. So in 7 days of bacteria, viral will not go into a secondary infection. Okay. So in all probability, what you thought were satellite lesions, you made a mention of satellite lesions, and then you made a mention of dendrites, seeing whether they were pseudodendrites.
Okay.
So in all probability, it was just a fungal infection, and it started as a pseudodendrite, and maybe that is how it got confused with the viral in the first place. Whoever saw the patient first time must have seen the earliest pseudodendrite and taken it to be a viral and put that patient on antiviral. So when the patient came to you, the pseudodendrites have got confluenced and they have become a fungal ulcer. So that is how I think is the chronology of your case.
Yeah, but still, is it also true that if you are giving oral, there is, even if there is an active viral ulcer, keratitis, we don't need to give a topical one?
If you're giving topical, you don't need to give oral one. We just saw the head study. We just saw the head study. If you're giving topical, you don't need to give the oral in epithelial disease. So oral does not solve any purpose. So
okay. And what about the mitomycin C eye drops? Does it have any indication other than OSNs?
I use only an OSSN. That too, wherever the histopath shows any invasion at the margins, and if the histopath margins are clear, base is clear, there is no invasion, I don't put them on mitomycin C also.
Okay. Okay, thank you. Though I joined in late, I'll take up the rest of the class.
Is it okay if I leave?
Yes, ma'am. Thank you so much. Very grateful.
Thank you, sir. Why grateful? And please stop calling me ma'am.
All women are ma'am.
Then it became ma'am again.
Okay. Anyway, it was great, really.
Thank you.
Thank you,
And
thank you,
we are
thank you.
one
Thank you.
platform
Thank you, Dr. Aishwarya. It was really great having you.
we reprimanded and so that we improve our patient care. That's the ultimate aim.
Thank you so much.
Thank you.
Thank you.
Thank you so much.
I thought